Okay, we'll get started. Thank you, everyone. Welcome, and thank you for joining us today for the PATH Live Forum titled Why Supply Chain Innovations Are Critical for Disease Management and Prevention. My name is Helen McGuire. I'm the Global Program Leader for Non-Communicable Diseases at PATH, and I'm delighted to be the moderator for today's conversation. We'll start first by going over a few logistics. We very much want to hear from you during this conversation, so please share your questions and your comments with us by submitting them in either the chat or the Q&A box at any point during the webinar. We really want to ensure that we have a dialogue, and we will have opportunities for you to ask questions later in the program. So please just log your questions as we go along, and we'll track those. So we'll have some time later in the latter half of the hour. And right now, just a chance to get everybody warmed up for today. I'll ask each of you a question. You can put your answer into the Q&A or the chat. Today's event is all about strengthening supply chains to ensure that people have access to critical products and medicines to manage and prevent diseases. And our speakers, our panelists, will share their work on this topic. But let's share together. If you have one innovation that has notably strengthened health system supply chains that you can share with us, or in contrast, if you have a supply chain challenge that you feel is particularly difficult to overcome, please, just a brief description in the chat. That would be great, and we'll review those in just a moment. In the meantime, just make sure your answers, of course, are going out to all panelists and attendees, and that's the same for when you're asking a question. So just please note, the call itself is being recorded, and it will be distributed to those that have been unable to attend. And this has been a great session. We already have 125 participants on the line. We've had more than 500 register, and we have participants joining from all over the world. We have government representatives, community organizations and NGOs, donors, as well as the private sector partners and others. And we really appreciate all of you in your busy schedules for taking the time for such an important issue in global health. So let's just take a look. We have some chats coming through. Great, thank you so much for your contributions. We have contribution, GPS tracking for refrigerated transport of vaccines is a great innovation. A barrier, items are not readily available when needed from suppliers, and backlogs of several weeks to months. And this is certainly that has come up in some of the assessments that we've done at PATH as well. We'll see if there's a few more that come through, and I'll keep going with our introduction, but I'll keep checking the chat. As an overview for our session today, I want to take this opportunity to introduce our panelists, and then I'll briefly frame our conversation before we dive into that facilitated discussion that we've talked about. So we are just so fortunate today. We have a fantastic panel. We're honored to be We're honored to be joined, by an incredible group of supply chain experts, and we just really appreciate them coming to join us and to share with us. We have Dr. Prashant Yadav. Prashant Yadav is, as many of you may know, globally recognized scholar in the area of healthcare supply chains and access to medicines. He's Senior Fellow at the Center for Global Development, Professor at INSEAD, and has been on the advisory committee for the Coalition for Access to NCD Medicines and Products, and has been a great contributor there as well. We have Bhavya Gowda, Senior Officer in PATH's Market Dynamics Program, and also serves as the Deputy Director of PATH's Living Labs Initiative. Welcome, Bhavya. We have Dr. Karan Sagar, Head of Effective Vaccine Management, Health System and Immunization Strengthening Unit at Gavi, who comes with us with more than 20 years experience, and he's currently focusing on immunization equity within primary healthcare. In addition, we have Josephat Smoy. Josephat is a pharmacist and supply chain specialist at PATH. He also comes with a long and great number of years of experience to join us today. So thank you very much, everyone, and to all the panelists for joining us. And now we will, okay, I'm just gonna go over to the chat. There's a couple more contributions, so we'll just share those. There's one that US Biologic focuses on thermostable oral vaccines to extend shelf life, eliminates the need for refrigeration, and facilitates cost-efficient logistics and delivery. There's a comment, Rick, about barriers, that thousands of ships wait to be unloaded in Shanghai, a very specific example. And we have a few others coming in. I encourage you to take a look at the chat to read some of those. So as we go through our slides, I'm going to move now to just say a few words about the supply chain and some of the challenges that we're facing. Of course, we know, and what you see on the slide there, of course, is a very simplified graphic of the supply chain, showing the manufacturer, procurement, the importance of information and data, storage and distribution, and service delivery. And we'll actually be hitting on all of these areas as we go through our discussions today. I think everyone on this call appreciates that the supply chain is the backbone of every health system, and a resilient, efficient supply chain is critical for governments, providers, and other stakeholders to be responsive to patient needs. It's an immensely complex system, however. There's many people and interdependent components that must work together to deliver supplies where and when they are needed. And yet, it's often under-resourced, despite its important role to promote, restore, and maintain health. In my role as the global NCD program leader at PATH, I've overseen several NCD supply chain assessments, considering availability, affordability, and inefficiencies and bottlenecks in the supply chain. And with each country that we've worked with, we've found different pain points in their supply chains, different priorities, but there has been common themes that have emerged. And so today we're really looking at 4 of them that we also have seen as being a great priority. And we'll frame our conversation around these 4 areas. Once we move to discussion, the panelists will describe their work and how they're working to break down these challenges. So the first one I'd like to share with you is the lack of quality local data. Supply chains in many low and middle income countries lack the quality data that policymakers and stakeholders require for forecasting supply, financial planning, and procurement. And this impedes their ability to match supply and demand. So improving data quality and use at all levels of the supply chain is obviously essential and important to reduce stockouts and out-of-pocket costs. The second area is really where we are placing, where these supplies, these commodities end up in our system. And is this the place that's most convenient for people that are seeking treatment? Often what we find in many countries that the services and commodities are concentrated at higher level facilities. And this is particularly true for non-communicable diseases. This requires patients to travel far from their homes to obtain the medicines they need. And during COVID, these services were often reduced by an estimated 50% based on WHO's survey. And there were a lot of concerns around the chance of increased transmission for those attending outpatient clinics in crowded hospitals. So investing in policy changes, the health workforce and equipment is needed so that we can shift these services to lower levels of care and out into the community. We know it can happen. It's happened for HIV. We can do it for other disease areas. Third, the rapid rollout of COVID vaccines really underscored the importance of adequate cold chain capacity and integrity. Transportation and cold storage must be reliable and maintained from manufacturer to patient. And when it's disrupted, supply is reduced for routine immunizations, COVID vaccines, and other medicines like insulin. So we need to think about, is the cold chain adequate, and how can we leverage the cold chain capacity that's present to cross the needs of the various needs that people living with disease, period, for prevention, but also those that are living with diseases. And finally, sometimes solutions that we design are often designed without the involvement of people with lived experience and those affected by the problem at hand. And this can result in reduced uptake and impact. So the importance of engaging with stakeholders from the start through a human-centered design approach brings exciting and often unforeseen results, but definitely leads to greater impact. And so we had this opportunity to have a great conversation about the role of human-centered design as well today. So our panelists will bring to us the innovations to break down these 4 barriers and address these 4 barriers to access and strengthen the durability and responsiveness across the supply chain. We'll focus on how to strengthen forecasting when data is limited and unreliable. We'll learn of efforts to strengthen cold chain integrity for vaccines and how human-centered design can strengthen access to products needed for disease management and self-care. And finally, find how making medicines for NCDs like diabetes and hypertension available closer to home within primary care facilities and in the community is not only possible, but it's really required for it to move forward and achieve universal health coverage. So again, I welcome all of you, and I'll now turn to our panelists to hear their expert contributions to this event. So to start off, Prashant, thank you again for joining us. You have been a real guide for the Coalition for Access to NCD Medicines and Products since its launch back in 2017. And one of the flagship projects that the Coalition has been working on is to develop a forecasting program for NCD medicines, which they've piloted in both Kenya and Uganda. Can you elaborate a little bit on why this was needed and what does it provide to decision makers that they didn't have before?
Thanks, Ellen. Thanks for having me, and thank you everyone for joining this interesting session. I look forward to your comments, questions, ideas about innovation. I think, like Helen pointed out, the different subcomponents of the supply chain have to all come together synchronously and seamlessly if we want to have a supply chain that delivers on its performance objectives, and the performance objectives being high availability, high service level, low wastage, high affordability, making sure that quality and other stringency requirements are appropriately met, right? So meeting all of those performance objectives requires the different pieces to come together seamlessly. Now, in supply chains which are for items that are needed for acute care, and Karan will talk about vaccines, we've seen similar things for malaria medicines, things which are required for acute one-time care, we've done sufficient amount of work to bring these different pieces together. There are tools, there are frameworks, there are technical training modules, and so on. When it comes to supply chains which have a chronic care component, which means there is a repeat visit, that's one part. The second is where you have to titrate and change the dosage or the form of medicines, whether it is for hypertension, diabetes, cancer care, etc. Things become complex. We still don't have all of the tools that bring together these subcomponents in a meaningful manner. We've done some of it for chronic care for HIV/AIDS, but that's, once again, there are parts of other non-communicable diseases which are much more complex than what we've been able to achieve for HIV/AIDS chronic care. So when you start bringing together the different components of the supply chain, one tool that ends up being very useful is forecasting. And when we think about forecasting, we ask, is this meant to serve the purpose of giving a purchase order, of determining how much will we purchase, of sending a plan to the suppliers, of deciding the inventory levels at the clinic? All of that is yes. But in addition, it serves a very crucial role, which is when we go about the process of forecasting, we have to make assumptions. In those assumptions, we realize where our bottlenecks are. When we start by asking, here is the epidemiological need in the population. Here is the portion of the population in the catchment area of a clinic or a hospital. Here is what we see from utilization data of how many are getting treated. You see the differences between those two numbers, and it helps you identify whether the starting barrier is in diagnosis, is it in screening, is it in bringing treatment, is it in financing, is it in procurement? So when the Coalition for NCD Medicine started its work, there was a huge task in front, which included all aspects of the supply chain. And we prioritized forecasting because we thought that will be one area which will help become the guidepost to what are the other things that need to be solved and in what sequence. So that was the starting point or the genesis of the forecasting work for the coalition. Once again, I think we've tried to make it very clear that this is not a forecast that is meant to decide how much will a clinic order next month. This is a forecast which is trying to understand the system holistically and is trying to understand where do we need to start advocating for either more resourcing or more technical tools or a combination. And that has been the vital and crucial purpose of the forecasting effort at the coalition. Back to you, Helen. You're muted, Helen.
Thank you so much. Thanks for those comments, Prashant, really bringing forward some of the really important, unique needs actually of people living with NCDs, that longitudinal care that's required, the tracking, the repeat visits, titrating those medicines, and also changing the treatment over time, which complicates, of course, the forecasting picture and the work that the coalition has done to bring forward some of the assumptions that need to be made, some of the gaps, and provide directions for next steps, including advocacy. So at this point, when we think about forecasting, when we move along the supply chain, of course, once things are forecasted, procured, then we have to ensure that these medicines and products move through the system and maintain their quality. And for some medicines, of course, cold chain integrity is incredibly important. So at this point, I'll turn to Karan and ask, this is something that you have been working on for some time. It's a key part of your work at Gavi. Involves replacing outdated cold chain equipment. And just wanted to get a really great understanding of this. How big of a problem is this in low and middle income countries? And what is the impact of this as you see it play out in these countries? Thank you, Karen.
Thank you, Helen, for having me here. Well, very important aspect here in terms of vaccine cold chain, because immunization supply chains, the cold chain is the backbone of vaccine supply chains. And as you may know, many of these immunization supply chains were designed or established about 4 decades back. However, they have helped us to reach a large majority of world's children. Before the pandemic, we were providing vaccines to about 85% of this, basic vaccines to 85% of these children. But because of the pandemic, there has been some decrease or a decline in that we have seen, and we're now reaching about 78% of these children with 3 doses of basic routine vaccines. However, the improvements have actually not kept pace. Now we are seeing that there is a massive increase in the value of vaccines, the quantity of vaccines that now need to be safeguarded. And as all of you know, most of these vaccines really require stringent temperature control. And part of these supply chains are now outdated and unreliable or unequipped to go to the last mile. So the whole agenda on equity that we're talking about gets really impacted if the supply chains and particularly the cold chain is not there, which is able to help support programs to reach the last mile. When we started the cold chain equipment optimization platform, when we were having this discussion, there was analysis which was done. And that analysis really showed that up to 90% of the medical facilities lacked modern cold chain equipment. And if you were to break that down, about 50% of these facilities were equipped with older devices, which were like the non-pre-qualified. We have WHO pre-qualified devices, but these were devices which are not qualified, or using kerosene or gas as source of energy. And these could really expose vaccines to damaging temperatures. About 20% of the facilities did not have cold chain equipment. 20% had cold chain equipment which was not functional, and only about 10% you can say had the latest devices. On top of that, you had several other challenges which we were seeing in cold chain equipment breakdowns, as I mentioned, and with poor maintenance contributing to the prolonged downtime of these equipments. One of the participants also asked about the temperature monitoring, the stringent temperature monitoring, and these previous equipments were it was really difficult to regularly monitor the cold chain temperatures, whether these cold equipments were maintaining the temperature ranges within the qualified range or not. Of course, you mentioned about the lack of data for decision making, and that existed for cold chain also. We did not know the performance data of these equipments, what's happening with these equipments without with the data, or even if the data was available, nobody was using that information and data. There are issues on the financial front as well. For example, the country ownership and sustainability still remains a challenge today as well, where we are even with the investments being made by the countries themselves and by the donors, we still see there are challenges which are plaguing the cold chain ecosystem. So I think all in all, if I was to sum up, these were the main issues and challenges which we saw when we started our work with the cold chain equipment optimization platform. And in terms of the impact you asked, Helen, of course, if you have the facility does not have an equipment, it is not going to provide the services. So your coverages and the impact on the disease is there in those communities, and can be seen in terms of local outbreaks or even at times epidemics. However, if the equipment is not maintained or is it not available at the last mile, it again really translates into low quality products being made available, and the quality of those products is compromised, and hence you would see an impact of those when you are giving those kind of products to the beneficiaries. They'll not have the desired impact. So I think a lot of things are there in terms of impact, the coverages, the reach, the quality of the product. I think these are all important aspects if we do not have good quality cold chain equipment, at least within the vaccine supply chains and for other primary healthcare commodities which really require refrigeration, as well as we're talking today in terms of the NCD program. Great. Over to you.
Thank you so much, Karan. It's shocking, isn't it, to think that 90% lack adequate cold chain equipment, that some of that is very dated, and the level of impact, of course, that can have. So we look forward to hearing more from you later in this session on some of the work that you'll be doing to address those challenges. Great. So now, Bhavya, we'll turn over to you. And just hoping that you can tell us a little bit about how market dynamics impact health products and services. And specifically, of course, would love to hear a little more about what we call Diabetes Care Pack, which is a project focusing on when it comes to commodities for managing diabetes and addresses the need for those commodities to be provided. Over to you, Bhavya.
Thanks so much, Helen, and thanks for asking me to be a part of today's session. So I'll start by saying that the key word here that you mentioned is access. From the outset, we center our approach around 5 components that impact access to health products and services. And you'll hear me talk about some terminology and language that both Dr. Karan and Prashant have already mentioned in their previous remarks. So hopefully this is one way to tie some of those themes together. So the first one that I'll speak to is around affordability. And some of the questions that we have been asking is, can the people who need access to these products and services afford them? Meaning, does it cost a product or service make sense for the supply side of the market, for manufacturers, suppliers, and distributors, and for the demand side and buyer side of the market, like governments, procurers, or patients? And the second is availability. Are these products or services available to consumers and patients, either supplied by the government or a private sector? You know, what are some of the stability and capacity of manufacturers and suppliers of particular health products to meet the potential demand? The third is assured quality, which is something that Dr. Karan just mentioned in his response. So do products meet high enough quality standards to work effectively, and keyword here, safely, as needed? The fourth is appropriate design. Are these products designed for the local context? Do they meet user needs? And do they help expand choice? And last but not least is awareness. Are consumers, providers, and health system decision makers aware of the products and services? I'm a member of the market dynamics team, and when we think about our work, we oftentimes incorporate market analysis to better understand some of these access-related questions that I just went through. Once we understand the landscape, we collaborate and co-design some of these potential market-shaping interventions that could potentially improve access to life-saving products and services. And as Helen asked, one of the projects that I support is the Diabetes Care Pack project, which is in its early stages right now and is conducted in partnership with several donors, ministries of health across a handful of countries, as well as people living with diabetes, healthcare providers, and other health system decision makers. When we think about availability of diabetes medicines and health products, one problem is that people with diabetes living in resource-limited settings often can't find all the products that they need in one place. So they could go to one pharmacy for test strips and a healthcare center to get syringes and somewhere else to get alcohol swabs. And as Helen mentioned in her opening remarks, people are having to travel very long distances in order to gather all of the medications and products that they need to manage their condition. So the Diabetes Care Pack project is trying to figure out whether it's possible to bundle everything that the person would need to manage their diabetes, which means they would be able to acquire all of those items in one place on an ongoing basis. Specifically through this project, we're also applying a human-centered design approach to ensure that this bundle of products, or the care pack, is appropriately designed. By keeping the needs and feedback of people living with diabetes at the forefront of our work, we have a better understanding of their current challenges and have designed the care pack to match their needs, with the hope of making these medicines and products accessible as accessible as possible for this group of individuals. Affordability is a key for any health product, and our project is trying to figure out who is responsible for paying for this. Is it the government? Is it the National Health Insurance Scheme? Is it the users themselves or donors, or some combination of all of these entities? What are some of the trade-offs associated with the care pack, especially as we explore some of these tough questions related to cost? So we're currently exploring and digging into some of these issues, which also might vary on a country-by-country basis. Each of these items, availability, appropriate design, and affordability, all link back to the supply chain. We have to think through where in the supply system does all of this happen. Where does the care pack get bundled, and who's responsible for bundling? Is it embedded within the public sector, the private sector, or both? And does an international actor develop the bundle and then distribute it to countries? Who pays? So these are just some of the questions that we're starting to dig into and are really excited to learn where our market analysis will lead us. Helen, back over to you.
Thanks very much, Bobby, and some tough questions, but we have such a broad engagement of stakeholders and et cetera, really feeding into this and engaged with this. We're, as Bobby has said, excited to see what will come in the future. Now, turning to Josephat, Bobby had mentioned access. She mentioned availability. And one of the challenges we've talked about is this concentration of services at higher level facilities. So turning to you, Josephat, I know you've been working with the Kenya Ministry of Health and also with Access Accelerated as well, and trying to bring medicines down to lower levels of care where they haven't been previously. And so really want to hear from you, your experience of people living with NCDs when they're trying to access medicines in Kenya. Sort of what were they experiencing before you went through this process of trying to bring these medicines down into lower levels of care? And what is the reality now? And do you see a difference in how this has improved their life, really, because of the reduced out-of-pocket cost, as well as the access to medicines has been facilitated for them? So over to you, Josephat. Thank you so much.
Thank you so much, Helen, and happy to bring this into perspective, the interventions that we've been able to initiate with the government and support of the partners. So Kenya, like most of the low and middle income countries, faces an increasing burden of non-communicable diseases. And from the stepwise survey that was conducted in the past in Kenya, actually we see a huge potential in terms of the impact of a functional supply chain and increased access to medicines. Of course, tied again to the behavior change interventions that can be rolled out for the NCD patients, with the potential to actually reduce premature deaths by 80%. However, in our context, we still see less than 50% of the patients actually being able to access these essential medicines and basic technologies for them to really manage these chronic ailments, especially the high burden hypertension, which we see a quarter of the population actually experiencing this condition. So right now, our country, majority of these NCDs are actually managed at the hospital level as the primary access points, despite having so many lower level health centers which are easily accessible to the majority of the population. The consequence of this is that now our patients have to travel quite far to facilities, and of course incurring a lot of expenses with poor road networks also in our countries, and again having to pay out of pocket for these medicines. And of course, this again, sometimes they end up in these facilities and find the supplies not being there. And again, this brings into perspective the importance of the forecasting work that Dr. Prashant mentioned. Sometimes with this limited availability in the public sector, we end up having these patients heading out to the private enterprise, and again, having to pay much more. And we see some patients actually not being able to access these products. And again, they come back to the facilities with complications, and majority of the families end up with catastrophic spending and sometimes mortality of these patients. So nevertheless, we are seeing a strong policy shift along with the increasing momentum to universal healthcare and the primary healthcare support, whereby we are addressing policy changes to make sure lower level facilities are able to provide this, and actually to facilitate these patients to be able to access medicines at those points. And this has been made more essential in this era of COVID, where there was a lot of hesitancy to access these higher level facilities, and also limiting exposure to these NCD patients who are actually at a disadvantage in terms of the potential to develop complications. So there's a lot of work towards capacitating these primary healthcare sites to be able to respond to NCD management, stronger supply chain, and also being able to diagnose and reach out to the communities. Over to you, Ellen. Thank you.
Thanks very much, Josephat. And it's really encouraging that you're seeing that shift. And we know that this is not easy work, that you have to be hitting this at different components of the health system, the policy change that you've referenced, the capacity building, getting the medicines down to those lower levels of care safely. So congratulations, and looking forward to hearing more. Okay, so we've gone through our first round of questions. We're going to have a second round, and then we'll go to some of the questions that the audience may bring forward. So again, I'll start with Prashant. And this goes back again to the forecasting program. Interested to hear a little bit about the impact of the forecasting program that was implemented in Kenya. It was implemented in both Kenya and Uganda, but we'll focus now on Kenya. And how do you see this effort improving access to NCD medicines and products into the future? And what can other governments do to replicate and build on this program?
Thanks, Helen. So I'll say three things. The first one is related to Josephat's work in bringing medicines for NCD or care for NCDs from higher level to lower level facilities. I think forecasting allows you to understand what levels of the system have the biggest constraints or bottlenecks. So if you make an empty-handed ask that let's bring care to the primary care level, I think the responses you hear both from the policy community and for actual implementers on the ground is, well, you have no idea how challenging it is to do diabetes care because you don't even know what cold chain capability exists at the primary care centers. How will we get the product out there? What kind of healthcare provider network will be available, and so on. So by systematically forecasting, we know what levels of care and to what extent in primary health centers you can do systematic NCD care where you cannot do, you know that, so you have a clear pathway to improve it. So it adds some more rigor and analytics to the idea of taking NCD care from higher level to lower level facilities. One particular example there, not directly related to our forecasting work, is the chronic care medicine dispensing depot work in South Africa, which I think it sometimes baffles us why we don't use that more systematically for NCD chronic care. The idea being that the first time a patient initiates treatment, they go to a high level facility, but thereafter, when they're getting their prescription refills, they don't need to go to a high level. In fact, they don't even need to go to a primary care facility. This can be made available to them at a pickup point in their community, which solves Bhavya's question on convenience, geographical access, but more importantly, it also decongests the system. Because if the number of people waiting in line to get just a refill of their chronic medicine while they're stable on all clinical parameters is just adding congestion to the health system, which is hurting other health outcomes for people who have acute conditions or are initiating their treatment. So we've got to make the CCMDD model work better. That's just a side ask. The second point about how the forecasting work has impacted is country governments in low and middle income countries have this communicable disease burden that still hasn't gone down. Donors such as Gavi and the Global Fund are asking them to transition, are asking them to increase their co-payments or at least start putting up a larger share of the total financing. That's one side of their health budget equation. The other side is NCD burden is increasing. It's becoming apparent that they have to spend more on NCD. So it's like this double whammy. In that situation, if we ask the government of Kenya or the government of Uganda or the government of Malawi to spend more on their NCD programming, in particular for buying medicines, it's a very hard ask if it is not precisely defined. So what the forecasting tool has enabled is to make those asks very precise. If you want to put X percentage population in need on hypertension or on diabetes treatment, here is how much budget allocation will be needed at the county level, at the federal level. Here is how it will translate into actual availability. So people can see in a vivid manner what is needed and what do you get in return for that. And that is a critical output from the forecasting piece, which is having impact because now there is a strategic plan that the governments have made. By incorporating this forecast, they are now allocating resources to that strategic plan. What can other governments do? Follow exactly the same pathway. If there is an NCD program that is still in stages of infancy, adapt the forecasting tool, develop some kind of forecast methodology to identify what is feasible, what is needed, and then use that to determine where can more resourcing help and in what form. I think that's to me, it sounds very straightforward. I would not say simple, but straightforward in terms of what needs to be done to replicate the kind of impact that has happened in Kenya. But I think there are lots of complexities. There is path dependency, and there is every country context is different. I acknowledge that, but at the same time, I think there are some ideas which are very straightforward and clear that need to go forward. Thank you.
Thanks, Prashant. Yeah, those core steps. I really like your statement around an empty-handed ask, and this came through in some discussions with NCD leads at the Ministry of Health. The importance of coming with local data, strong rationale for what they were bringing forward, adding that rigor to the discussion. Recognizing that double burden challenge, and the need to be precisely define what is needed. And what will that mean going forward? Recognizing the success in Kenya and what could potentially be achieved in other countries. So thank you so much for that. I'll turn now, Karan, to yourself, and really wanting to hear more. You talked about the incredible need that's out there with respect to cold chain. So how is the cold chain equipment optimization platform access to routine immunizations and even to COVID vaccines? How is that helping? Is there an opportunity even to utilize, is there any capacity in the system, sorry if I'm not being clear, Is there any capacity in the system as you start to look at this and you start to work through the optimization platform for that cold chain capacity to be used for other medicines such as insulin? I'll turn it over to you. Thank you.
Great, thank you so much. Maybe I'll start by giving a brief introduction to this platform, as maybe some of the members here today may not know about it. So as I mentioned, there were several challenges when we started the CCOP program. And so Gavi actually established this platform in 2015 as a strategic and a targeted approach to address the challenges of improving the vaccine cold chain with higher performing cold chain equipments. And there were particularly three objectives which were there. One was to ensure that functioning cold chain equipment is available where it is needed to support coverage and equity and to protect vaccines, help countries introduce new and more efficient climate-friendly technologies which are better suited to their needs, and also shape the markets to help accelerate innovations and improve supply and reduce prices. So this platform, which was initially started with a $250 million co-investment funding model over a Gavi 4.0 period, which was 2016 to 2020, and it, as I said, aimed at improving the availability and installation also of high quality equipments, which we were seeing as a bottleneck in the previous programs. So we have seen a lot of success around this, and based on that, Gavi board actually approved additional investment, again on a co-investment model of around $150 million for CCOP during the current strategic period. So this will definitely help countries to benefit from the support, and we will be able to see much more improvements in how the vaccines are handled and managed at the last mile. As I mentioned, we're also working to shape the markets for cold chain equipment by accelerating the innovations and helping to lower the prices over time. And what we have done is this platform has actually created an innovative mechanism to shape the cold chain equipment market and incentivize countries to transition to more cost-effective and sustainable cold chain equipment. What we are supporting countries is, as I mentioned, PQS, but within the PQS, the innovation is around grade A equipments, which really require very little human interactions for them to maintain the temperatures within the ranges required. And they are functioning at wider ambient temperature ranges as well. So there is an innovation. Some of these equipments are coming with temperature monitoring, remote temperature monitoring devices. So you know whether when the equipment is functioning or not functioning, or whether it is able to maintain those ranges or not. So I think there is a lot of innovation which has helped, which has gone in. In addition to this, as you mentioned about COVID, obviously all of this was done at the last mile. So majority of this equipment is going to these peripheral facilities or up to the district level and facilities below. However, there is still need at the higher levels, and the COVID pandemic actually showed us that. When the pandemic hit, we did an analysis and we found out that the requirements at the national level to intake of these vaccines, to take these vaccines and distribute them, was also constrained. And that is where Gavi then, through its COVAX facility, started to support cold chain at the upper levels, so that we are able to store the COVID vaccines in most in the acute setting. Of course, the intention is once this pandemic phase is over, this equipment routine, and there will be enough capacities available for the vaccines. Quickly, 50 from this support, and we have procured about 67,000 units of these highly equipment. About have already reached the countries and have been installed. And through the COVAX, additional for the national level, these are about 200 and similar freezers are being procured in addition to passive devices. So a lot of enhancement is going into this space. And as you asked, how this can help the storage of other NCD commodities. I think in the peripheral facilities, if you look at a number of times, the storage volumes are for the vaccines are met, but then there is additional storage volumes which are still available to store the other primary healthcare products. And having looked at that, we worked with WHO and UNICEF to, obviously there was already some joint statements from UNFPA and UNICEF around storing other commodities, but it was not being implemented. Now we have established guidelines which the countries can use to store other commodities within the EPI fridges. Obviously, still a lot remains to be done in terms of communicating those guidelines, helping countries imbibe and implement those guidelines. So that is something which we are looking at going forward.
Okay, thank you so much, Prem. Exciting advancements, and really interesting to hear that it's not, with the newer the newer equipment that you have, that it's not just about getting that equipment in place, but it's actually changing the way that it needs to be monitored going into the future, and is a more efficient approach going forward. So it has lots of benefits on both sides. So thank you for sharing that. We're really encouraged to hear that there may be some capacity for insulin to be included in some of those, in using some of that equipment and capacity. So I'll turn, Josephat, I'm going to turn over to you. And I'd like to hear more about the rollout of the primary healthcare strengthening efforts in Makueni County, specifically county in Kenya, and the access to medicines at the primary healthcare level. Just if you can say a little bit more about how that's rolled out, the impact of that.
Thank you very much, Helen, once again. From our work with the Access Accelerated and of course with the leadership of the Ministry of Health Kenya, we've been able to initiate the primary healthcare support for non-communicable diseases, whereby now our patients are able to access care at this very low level and not having to travel very long to access the hospitals. So in partnership with Medtronic Labs, another key partner in the country, we've been able to make sure patients are being seen from the health center by the readily accessible healthcare worker, and also from the community level, they are able to be tracked without having to come to the hospital on routine basis. We're able to reach out and take their vitals so that we know if they are stable or not. So we started off with one facility which was hard to reach, and in most instances you would see complications on every month, about 10 patients coming in without medications and having complicated. So this had about 260 patients, and it's a rising number now. It's about, I think, 300, where we went in and capacity built the facility, trained the healthcare workers, and actually initiated a network to a number of hospitals around where patients were now referred to this facility. So we've been able to manage these patients consistently, and with the existing drugs that are actually availed by that high burden county, which also is piloting a universal healthcare model. So having run this through a couple of months, we no longer see complications arising in this cohort of patients. And now the county was able to scale up to additional 10 facilities in the start of this year. And we are now seeing ourselves reaching over 5,000 patients who are now able to avoid going to these hospitals. And added to this, they are able to benefit from not paying for these medicines, and of course, now addressing the affordability question. And we are actually seeing going now into expanding this across the country. So this has been a very good learning model, and being able to access their data on a continuous basis from the community level. And we've also been able to actually identify new patients who previously did not come to these facilities because of distance. So in their markets, in their local meetings, we're able to walk in and take their measurements and be able to link them to these facilities. So this has been really wonderful, and in supporting them to access medicines during COVID. Thank you.
Okay, Thank you very much, Josephat, for sharing that. I'm just going to note that there are a number of questions in the Q&A box. And Karan, if you could respond to some of those perhaps directly into the box, and Prashant as well. There's also one for Bhavya. And in looking at the time, I don't think we're going to have time to cover them all. So if you're able to put in a few comments, that would be appreciated. Bhavya, perhaps I'll go over to you just to provide you with your last question around healthy supply chains contributing to more person-centered care and really getting us closer to universal health coverage. So two components to that question. What is the connection between supply chains and person-centered care? And then how does that all link to universal health coverage?
Thanks, Helen. Thank you. So supply chains have a huge impact on healthcare, as we have heard over the last hour or so, and how, when, and where, and at what cost people access health products that they need. So building and maintaining healthy supply chains are absolutely critical for ensuring that they work for healthcare providers, suppliers, and ultimately the people who are actually using the products. Strong supply chains are especially critical when introducing new products. Dr. Sagar mentioned the vast complexities that the global community has gone through in order to integrate COVID vaccines into supply chains. And so I think that's just one example of the criticality of supply chains in order to introduce new products. And when products are more easily accessible for the people who need them, it's one factor that hopefully leads to higher likelihood of use and adherence to treatment regimens, as opposed to stopping treatment earlier because it's just too hard to get what they need. So going back to the diabetes example that I referenced in my first response, many people don't have access to monitoring their glucose levels on a regular basis. And our hope and desire is that with the Care Pack project, these individuals may have the ability to self-monitor regularly to better manage their condition, enabling an element of self-care. So going on that word self-care, strong supply chains can also contribute to a more person-centered care by expanding self-care options, which is a WHO priority, which enable a person to take control of their own health and well-being. And when people can do that, there's hopefully greater equity in health, and that's one key piece of the universal health care coverage puzzle. Helen, I'll keep my remarks short since we're short on time, so I will end it there and pass it back over to you.
Okay, thanks so much, Bhavya. I see, Josephat, you'd like to respond to one of the questions live, so I'll give you that opportunity. The question is wanting to share thoughts around how co-packaging the products might solve some issues. For example, syringes and swabs are multi-therapeutic, and co-packaging them ensures availability for use in diabetes care, but may introduce additional complexity since the products in the pack are variable in their need for cold chain storage. How are you weighing these costs and benefits beyond availability to the end user? So turning that to Josephat for a response.
Thank you. Just happy to chime in a bit. So as we've been part of this co-packing work in Kenya for the diabetes products, yeah, we'll be able to appreciate the challenge around the cold chain aspects, where now in that we were not able to put in insulin in that pack. But again, with the co-bundling work that we've done, we've been able to realize the patients are able to access the syringes, be able to get the strips within one bundle, as opposed to a previous experience where they had to go to a laboratory for the testing and syringes from a different clinic. So there's that aspect in terms of co-availability in one spot. But again, we are still weighing the cost implications in terms of the self-care aspects that the patient will now have to cater for. Thank you.
Great. Thanks so much, Josephat. And I'm going to push the clock here a little bit. Prashant is prepared to answer this question live. UNICEF has been leading the efforts for routine vaccination needs, including syringes. With COVID, the supply division had to take on a new role in procurement in the time of a pandemic, for which they were not designed to lead. Challenged by the non-standard vaccine doses of one of the vaccines, how do we think the vaccine ecosystem will need to change that they will be able to design pandemic preparedness into the permanent scope of responsibility, or another stakeholder that will need to have a strategic approach to avoid a situation that we have heard so much about? Over to you, Prashant.
Thank you, Helen. This can take up a long period of time, so I'll be very very quick and short. I think it's an important and salient question. I think, the idea of the 0.3 ml auto-disabled syringe is just one example amongst very many where we need stronger coordination in the vaccine ecosystem. And the ecosystem here includes critical components that go into vaccine manufacturing, ancillary supplies that are required for immunization. All of those things have to come together. And yes, the supply division has been playing this role, but I think we need to think about a governance structure which is at a higher level, such as the G20. I think a recent National Academy of Medicine expert committee that I chaired, we thought through this issue quite a bit and said the only way we think this can work would be if the G20 or some other inclusive structure, G20 plus WHO plus others, creates a coordination task force, which would be somewhat similar to the COVAX Supply Chain and Manufacturing Task Force. That would solve the problem, because then it's not just about who's purchasing the 0.3 ml, who's purchasing the 0.5 ml, who's allocating it, but rather someone has a full bird's eye view and can collaborate and coordinate as needed. I think that's the governance structure we ought to start thinking about if we are serious on preparedness. Thank you.
Thanks very much, Prashant. And I'm just going to give you a chance to say a word either on the questions, but also a closing statement. As we'll do the closing statements now, but if you want to combine some of the answers to these questions, that's great. Thanks, Karan.
Yeah, thank you. I think there was a question on innovations and whether we are promoting or not, and whether the current ecosystem allows for that. I think it is very important. And as you've seen, once we launched the CCOP platform, that actually spurred a lot of innovation in the space. We were having very limited number of manufacturers prior to the CCOP, but with CCOP advent, number of manufacturers, number of products, innovative products coming into the space has increased, and we are continuing on that in that direction. And of course, one of the mantras for Gavi is innovations. So be it in terms of program delivery or be it in terms of the products that we support. So I think there is a lot of scope for the new innovators. There are funding mechanisms which are available through a program called Infuse, which can help you to kind of test your hypothesis. Every year there is some kind of a theme which comes out. So there are, and we have seen in the past some of the innovations in cold chain occurring through that Infuse program. In closing, I would say, I think it is very important to understand, and for Gavi, for us, I think the main aspect in Gavi 5.0 is reaching the zero dose populations with immunization and reducing the number of these zero dose by 25% by 2025. And supply chains will play a very, very important role in reaching these zero dose, these populations being urban poor or remote or rural communities, or even children who are affected by conflicts. And strengthening of the supply chains is going to be very, very kind of important in terms of not only delivering the services to these communities, but also ensuring that the vaccines which are made available are potent, and we are maximizing the efficiency where possible. And last but not the least, it has to be really strategies which are addressing country needs and are tailored to the country context. And that's what we are trying to do through our updated immunization supply chain strategy, where we are looking at not just the infrastructure investments, but also the other elements which need to be strengthened along with the infrastructure for the supply chains to be robust and resilient to reach the last mile and help bridge this gap of zero dose children in these communities.
Thank you so much, Karan. Prashant, did you want a closing? Would you like to share a closing statement? Thank you.
Innovation across different therapeutic areas. What we've learned from chronic care and HIV, trying to implement that in NCDs. Also bottom-up innovation, giving people and a wider community a chance to think about what solutions can solve supply chain problems. I think our world of creating supply chain solutions in Washington, DC, Seattle, Geneva, London, elsewhere in the world is not what it's going to solve. So we need a innovation ecosystem like Karan said. Thank you.
Thank you so much, Prashant. Bhavya?
Thanks, Helen. So in closing, I want to reiterate that billions of people have limited access to quality health products and services. And as we've heard today, strong supply chains can enhance access to those commodities when market dynamics components like affordability, availability, assured quality, appropriate design, and awareness are all taken into consideration. And lastly, I just want to thank you all for the opportunity to be able to share the market dynamics approach and discuss the Diabetes Care Pact project today. Thank you.
Thank you, Bhavya. Josephat?
Thanks, Helen. And just to say, taking the conversation around the last mile availability is really key. And we've been able to understand that it is really great to leverage on existing programs that have worked in the past. And innovations are actually ripe for this. And also the primary healthcare conversation has really kicked off in most of the low and middle income countries. Thank you.
Thanks very much, Josephat. So I want to end our discussion today by thanking all of the panelists for joining us. It's been great what you've shared, the insights, etc. One thing that's certainly clear to me is the importance for that multi-sector approach. Clearly, this is a complex issue. We have to work together. We have to use the investments that have been made in communicable diseases to help us advance supply security for non-communicable diseases as well. And I think we're starting to see that happen, and that's an extremely exciting advancement. So thank you for joining us. Thank you to all the audience, and we look forward to being together again soon. Thank you.